first speaker this morning is Dr. Stephen Liang. Stephen is from Maryland, and he completed our EM-IM program in 2009. After that, he went down to St. Louis and did an ID fellowship. So he's one of the very EM-IM and ID boarded. And as you expect, he's focused his niche on emergency infections. And so he's going to kind of kick things off by giving us a little bit of background and basics on COVID. I can't think of anyone who's more qualified to do that. So Stephen, you want to go ahead and unmute and take it away? You might still be muted, Stephen. At the bottom left, there's a mute button.
Good morning, everyone.
Great.
There you go.
Thank you. Sorry about that. Can everyone see the screen okay?
Yep.
All right, great. It's a privilege to start off this day with you, and I want to thank Amal, Brian, and Michael for the opportunity to be here today. What I titled the talk was COVID-19, what we know today, because the truth is what we know today is different from what we knew 60 days ago. It's probably going to be different from what we know 60 days from now. But this is what we know today.
Stephen, is there a way you can just show us your slides? We're seeing your presenter notes too.
Oh, yeah. Oh, sorry about that. Let's see what's going on here.
If you click on display settings up there.
I apologize.
It should come, if you just hit the slideshow, it should come up. I'm not sure why it's doing that.
Yeah, I'm not sure why it's
Display settings. If you go to display settings at the top.
I'm going to slideshow here. Right
no, it was on the other screen. If you start the slideshow, at the top where it says display settings, you can swap the views or duplicate slideshow, and then there you go.
There we go. All right.
Very good. Okay, sorry about that, guys. All right, so even if you weren't around for SARS, MERS, Zika, or Ebola, the truth is you've had a front row seat to the emerging infectious disease of the decade, I would say at least. And this is COVID-19 caused by the virus SARS-CoV-2. I want to give you some context as far as emerging infectious diseases. 101, I want you to think about COVID-19 and all these aspects of emerging infectious diseases. So the things that kind of contribute to the evolution of emerging infectious disease can include changes in demographics and behavior. And we've seen that with the whole rural to urban divide and the fact that populations are getting closer and closer. So you have populations from rural areas coming to urban areas and potentially bring infections into urban centers. We have changes in the environment. We have the breakdown of public health measures. So war, famine, poverty, social inequality. Certainly we've seen that play out in terms of poverty and social inequality in the current pandemic, as well as a lack of political will. We have microbial adaptation. So viruses and bacteria find ways to jump from host to host, from animals to humans, in the setting of a changing ecosystem. We have a smaller world where people are traveling by a plane. You can be anywhere in the world within 12 to 18 hours. Certainly we worry about the intent to harm with biological agents, not so much the case with SARS-CoV-2 as far as we know, and certainly changes in technology and industry. And all these things really kind of come together to create this perfect storm for an emerging infectious disease. And I think that you can say that COVID-19 is in many ways very much this story. To give you a little background, coronaviruses are single-stranded lipid-coated RNA viruses. And basically, you have the spikes here of the coronavirus, and that's where it gets that name, the crown, coronavirus, and then that lipid envelope, which is very easily dissolved with most of our disinfectants and soaps. Coronavirus is first discovered in 1960, and you'll see that throughout the years, we found many different types of coronaviruses. Most of them are cold viruses. In 2000, and actually in 2003 and 2004, we discovered SARS-CoV virus. That was the original SARS. And then a couple years later, MERS-CoV, And then now in 2019, 2020, we have SARS-CoV-2 or COVID-19. This is kind of a family tree of your coronaviruses, and your alpha coronaviruses typically are your cold viruses. Your betas include your cold viruses, but they also include kind of these emerging infectious diseases like MERS here, and then SARS here again that we saw from 2002 to 2004, and the most recently SARS related to SARS-CoV-1. That's why they're got the same name there. So the story really starts back in December, as you know, and what we're finding more and more with each day is that there probably were cases of SARS-CoV-2 circulating in different communities, even on different continents, as early as December of 2019. However, the first case was identified in China in December, and then the first cluster in a wet market in Wuhan, China, at the end of December. Within 2 weeks, they were able to sequence the entire virus's genome, and within another 2 weeks, we had confirmation that this virus was indeed transferred from human to human. 10 days later, the World Health Organization declared a public health emergency of international concern, which is their highest level of concern. That's been given to Zika, given to MERS and SARS before in the past. It's only been done 4 or 5 times in the last 25 years. The next day, the United States declared a public health emergency. In March of 11, a pandemic is declared. And just to look at the kind of speed of things that have happened with COVID-19, again, that first case identified in December, within 3 months, all of these things happened compared to SARS, where it took about 6 months or so. And I remember SARS back in 2004 as a sub-I at Mercy Medical Center and just watching that play out. And in many ways, there are lots of parallels. To give you a sense of the world right now, as you know, the United States leads in the number of cases, confirmed COVID-19 cases per million people, as well as several other industrial countries in Europe, certainly in South America. Obviously, China had many cases as well. You've probably seen this graph, I imagine, in the lay press, but it really gives you a good sense of how exactly we compare to the rest of the world. Again, the number of cases in the United States are really far exceeding the rest of the world, and part of that is related to test capacity, but part of it is also related to spread and transmission as well. This graph is probably a better indicator of what we should really be looking at, and that's the number of daily confirmed cases. You'll see here that in many cases, other countries have been able to bend this curve so that they've reached their peak number of cases and then bent the curve downwards. The United States here, there's still greater than 10,000 cases identified every day. We still have yet to bend that curve, so there's still much work to be done. As far as the transmission of the disease, it's primarily a disease that affects the upper and lower respiratory tract, so it binds to the ACE2 receptor in the respiratory epithelium. We believe that's transmitted primarily by respiratory droplets. These are usually droplets measuring greater than 5 microns, as well as by direct contact. As far as shedding, we know that most folks will start shedding within 24 to 48 hours of symptoms prior to symptom onset. So this is virus that's being actively produced and then shed through your respiratory epithelium. It continues for the next week or so for mild to moderate cases of disease. For severe diseases, people can shed for far longer. Shedding is usually worst first in the acute phase of the disease. We do know that people who have recovered from COVID-19 may have intermittent shedding later on. But the truth is, a lot of the virus that they're identifying by PCR is probably not viable. They've tried to culture viruses from these folks later on, but they've not had much success, which is a good sign. As far as the transmission, like I said before, this is primarily a respiratory droplet disease. So that's where you get that 2-meter radius around the patient for your droplet precautions. In addition to that, certainly droplets that have landed on fomites, that have landed on objects in the environment, that can also be a mechanism for transfer of the virus. With some situations, certainly aerosol generating procedures like intubation, that can create really fine particles that can travel far distances. This is really thought to be a minor part of the transmission cycle for this disease, though we do recognize it, particularly in the setting of critical care. As far as the disease itself, its most common presentation you're probably very well familiar with. Within the first week, you have this prodrome of myalgias, malaise, cough, and low-grade fever, followed by the progression to dyspnea. The median incubation period is about 5 days or so, and as far as recovery, mild cases usually take about 2 weeks to recover, severe cases anywhere from a month to a little bit longer. This comes from a large Chinese case series. About 44,000 cases of confirmed COVID-19 in China were reported at the end of February, from what I recall. And basically, COVID-19 is kind of broken down into three categories. So your mild cases make up about 80%. So the vast majority of cases are mild cases characterized by a viral syndrome with cough, loss of smell. About 15% of cases are complicated by pneumonia, or viral pneumonia, and about 5% of cases are complicated by respiratory failure, septic shock, and acute kidney injury. And really, this category of critical cases and severe cases is usually going to be this population with many medical comorbidities. So certainly age, pulmonary disease, hypertension, diabetes, chronic kidney disease, and so forth. All these things, as you would imagine, would put you at risk for severe disease, as you would see with influenza and other viral infections as well. In this case series, about 2.3% of all cases died. As far as the diagnostics, so currently, in the current state of the art is this RT-PCR, which is obtained through a nasopharyngeal swab. Now, that's again a reminder that a true nasopharyngeal swab is pretty deep, so people should be crying when you're doing this. Certainly, you can get that swab from a nasal sample as well as from the oropharynx. We are looking at salivary samples as well as a way to conserve our MP swabs, because we are very quickly running out of those. Certainly, lower respiratory samples from a bronch are pretty good diagnostic for obtaining this PCR as well. It's important to note that there is a small amount of false negative that's positive with this test, and that's usually related to sampling technique, as well as probably the phase of infection the patient is in. Once the patient stops shedding virus in the respiratory epithelium, you would expect this RT-PCR to shut down and turn negative. In the last couple of days, we've had the FDA approve a serology, so an IgG for SARS-CoV-2. Now, this again will tell you about past infection. We're still not sure whether or not it tells you about protective immunity. So you may have the IgG, but we're still not sure whether you're mounting a neutralizing antibody response to the infection. I think there's still a lot to be learned about this, how to use this IgG. It's important to note that this IgG should not be used to diagnose active infection. In addition to looking for COVID-19, you also want to look for co-infections early on in the pandemic. During the flu season, we're certainly looking for RSV and flu, and it was really interesting. I'm not sure if you guys probably experienced the same situation where we saw with the arrival of SARS-CoV-2 and the implementation of social distancing, that our flu numbers basically plummeted and nosedived to the ground. So flu basically disappeared once SARS-CoV came. As far as imaging, your chest x-ray will show this typical viral pneumonitis if someone has progressed to that stage, and certainly the CT can show kind of non-specific ground glass opacities that are thought to be related to a viral pneumonitis from this infection. The labs, you've heard about the low white count, particularly lymphopenia, certainly the elevated LFTs, inflammatory markers, and D-dimer. Therapeutics, supportive care, really that is the only known treatment for this disease, the only proven treatment for disease at this point in time. Certainly a lot of our colleagues, I look forward to hearing their stories about the critical care management in terms of O2 proning and ventilator strategies. As far as other things, remdesivir has now just been approved by the FDA for emergency use authorization, and this is based on a large US trial that is still in progress right now. It's the ADAPT trial, Adaptive COVID-19 Treatment Trial, that involves 1,063 patients across the country. And what they have seen so far is that the addition of remdesivir has decreased the time to recovery from 15 days to about 11 days between those two arms. So there's a decrease in time to recovery. The story certainly sounds a lot like the oseltamivir story, but we'll wait to see what the effect is in terms of mortality. Important to also highlight this competing study that came out also this week in Lancet from China, Hubei province, that basically showed no significant impact in terms of recovery time or mortality with the addition of remdesivir. That was a small RCT, and there was definitely a lot of discussion about whether it was adequately powered for the outcomes it was looking for, because at the time that RCT was performed, China's numbers were already starting to decrease. As far as other therapies, you've heard about convalescent plasma. So this is harnessing the antibodies of recovered patients to provide passive immunity to other patients who are infected with SARS-CoV-2. the use of multiple drugs, lopinavir, ritonavir, and HIV combination drug, which did not show any significant impact. Certainly, you've heard the hydroxychloroquine story that wound a lot of people in a lot of trouble. Certainly, IL-6 inhibitors, tocilizumab, we used at our institution with not so great effects, and certainly the story of using steroids as well. None of these have really panned out just yet. I think we'll just have to wait and see what else comes through the pipeline. Really, why I think ultimately, certainly there are many companies that are looking at vaccines, and we hope within the next 1 to 2 years or so we'll have a potential candidate. As far as prevention, this really hinges on some very basic things. So the importance of hand hygiene can't be overemphasized. This virus is extremely easy to kill, even with just soap and water that dissolves the lipid membrane of the virus. Alcohol hand sanitizers are perfectly fine as well. You guys are well acquainted with personal protective equipment. Based on our understanding of the disease itself as a primarily respiratory droplet-borne infection, droplet contact and eye protection is very sufficient for managing most patients. However, if you're talking about an aerosol generating procedure, we do recommend the addition of airborne precautions. So that's the N95 respirator or a PAPR, as well as isolation in airborne infection isolation room. Many of our institutions have looked at extended use and reuse. At our institution, we are using vaporized hydrogen peroxide to disinfect N95s and return them to the user so we can try and extend our supply a little bit further along. So this is one of those crisis contingency situations where we found creative ways to reuse what we thought was supposed to be disposable PPE. That's the best that we've got right now. I want to emphasize the importance of environmental cleaning and that most hospital-approved disinfectants will also kill the virus. And really, this is the unsung hero of the pandemic. So if you do see your environmental services folks today, please give them a very, very gracious thank you for all the work that they're doing. That's very much under-recognized. Other strategies, certainly you've heard about universal masking. We've gone to that at our institution, and the importance of social distancing. So like I said before, what we know about COVID-19 seems to grow with each day, and certainly I'm interested. It's interesting to look at what we thought we knew 60 days ago and what we're going to know in another 60 days or so. Definitely, it's been a trying time for all of us, but I think emergency medicine has been at the forefront of this pandemic. I'm very proud and honored to be part of this talk today.
All right, thanks, Steve. That was great. We've got time for a couple of questions, if anybody out there has any.
I have one. Hey, Steve, thank you so much for coming back to speak with us. It's so great to have an alumni who's got the expertise that you do in this at this time. I just was hoping I could pick your brain about the possibility of a vaccine. What would be the likelihood of that and the time horizon?
That's a great question, and there are lots of people that are hot on the trail of this. From what I understand, there's actually, so Pfizer has a lab here in St. Louis, and they're working with a German company to start producing a candidate vaccine. But really with vaccines, there are steps that need to occur as far as efficacy and safety before it can be used in a large setting. With the Ebola virus, we did see vaccines come online very quickly, and they were used in kind of crisis settings when the West Africa outbreak occurred. So I do think that there will be progress. There's certainly, I think there's a lot of debate also about whether or not we can whether or not we can develop an effective vaccine against a coronavirus, since we are so many coronaviruses and we've never had a coronavirus vaccine before in the past. They've tried it with MERS, and they've had kind of so-so success with that. So I would say it's very guarded, but a lot of people are working very hard and very fast on this right now.
Okay, thank you.
That's Mike.
Steve,
A
one
question just popped up. Is there any evidence of like clinically relevant mutagenesis?
Oh, that is a great question. I would have to take a look at that. As far as, so we're talking about the seasonality that you see sometimes with other viruses, including the flu virus, and whether or not there are changes in the SARS-CoV-2 virus. I have not heard of anything concrete yet, but that definitely is a concern for sure.
What are your thoughts about us developing long-term immunity to it? Sorry, Al.
Initially,
That's right.
yep. So initially we thought that most people who had this infection would develop a durable and very robust immunity to it. There are definitely lots of studies going on in terms of, like I said, neutralizing antibodies, trying to determine whether or not those antibodies actually effectively block the virus. I'm hopeful that there will be, but I don't have as much confidence as I did about a month ago when we were talking about this. I think that there have been some questions about additional cases with people who have recovered from COVID-19, whether or not their secondary positive PCRs were reinfection or just a kind of a breakthrough of shedding or something along those lines. I don't think the story is very clear yet. So yeah, as far as durable immunity, I think it remains to be seen. It's too soon to say.
Okay, Steve, thanks so much for your time. For as long as you do have time, it would be great if you stayed on, and I'm sure other questions are going to come up along the way if you want to participate in that Q&A. Also on the chat line, if anybody, any of the speakers or other folks want to